Well, good morning, everybody, and welcome to this session, which will be presented by David Crewe-Brown, CPIM, CSCP. David is a passionate supply chain practitioner who has more than 20 years experience in supply chain management across the fast-moving consumer goods and more recently, health supply chains. He is currently the technical supply chain lead on a large multi-year USAID project to strengthen health supply chains in South Africa. David previously led the implementation of a centralized planning operation for SAB Miller across Southern Africa. He is an active SAPIX member, an industrial engineer, and holds an MBA from the University of Cape Town. Thank you very much, and over to you, David.
Thank you very much, Colin, for the warm welcome, and good morning, good afternoon, good evening to all the delegates. Wonderful to be with you, and hopefully in person soon. Thank you to SAPIX for the opportunity to speak, and well done for pulling off this amazing online conference. I think COVID is really forcing us to dig deep and come up with very innovative ways, and it's been wonderful to see how that's been true in this conference. Let me just get ourselves set up here very quickly. So, have you ever saved a life? A colleague and a dear friend of mine recently was tragically killed or died whilst trying to save somebody in the sea. Lindile was based down in the Eastern Cape. He was a pharmacist and worked very closely with us, and really has become a supply chain practitioner. So we would remember him fondly, and really celebrate his historic and heroic act of selflessness. But not many of us get a chance to save a life every day. As Colin mentioned, I now work in the healthcare space, and I believe that I help save lives, not from drowning or from a fire, but by providing much needed medicine to facilities, hospitals and clinics around the country to ensure that when a patient arrives with a life-threatening illness or ailment, HIV or TB, that they can be saved. Good morning, ladies and gentlemen. Again, my name is David Crewe-Brown. I work for Guidehouse, part of the USAID-funded project, providing technical assistance to the South African National Department of Health. Today, I'll be sharing my story of saving lives by making the right medicine available in the right place at the right time, and by optimizing the replenishment planning framework. So a quick context of South Africa's healthcare system. It's a significant healthcare system that spends 20 billion rand just on medicines alone. Patients are serviced through about 4,500 facilities, and these facilities range in size. There's some that are quite small that will keep, like a clinic, about 200 products, and some of the big hospitals that will keep up to 2,000 different products. South Africa also has one of the largest HIV treatment programs in the world. And in that treatment program, we need to make sure that we get medicine to around 5 million people every month for their treatment program, to stay online for their treatment. So the challenge for the pharmaceutical services and pharmaceutical supply chain is to make sure that we have enough stock available at the point of serving patients to meet the healthcare needs of around 47 million people in the country. And that's a significant challenge. And today I'll be telling you a bit about that story. So inventory is something that I think everybody on this call would know very well. It's having the sufficient product at any point in time to meet a customer's requirements. It's like your pantry. Pantry at home, we've got some extra coffee. Not too much, because coffee is expensive and fresh coffee is the best. But we have enough to make sure that when the current batch runs out, we avoid a disaster. So setting the right levels of inventory is always a challenge. If you have too much inventory, you have the inevitable cash flow that's tied up, or working capital that's tied up in the product. You've got kind of full facility and you potentially are standing at risk of writing off. If you do not have enough product, on the other hand, you are at risk of stocking out. And that is often, in our environment, a more serious dilemma to deal with. I love this quote from one of my mentors way back who said that inventory is a good thing as long as it keeps on moving. And in our case, moving towards the patient. So in pharmaceutical services, there are really good management questions to ask around how do you manage your inventory. Really, the first one, which items should be kept at the facilities? And we call that a formulary in our environment, a formulary of the medicines that you need to keep. Then we look at, well, what's the frequency of orders? Do you order daily, weekly, twice a month, monthly? What is the frequency that you need to order on? How much stock do you need to serve the patients that you have? Also, what is the buffer that you need to balance for the demand and supply variability? And often there are times with higher demand. If you think about COVID times, we saw increase in demand in some medicines. And sometimes there's lead time disruptions. Again, with the experience we've had recently with COVID, your lead time can get very long if suppliers have not been able to buffer themselves with stock. And then the last question is, what is your replenishment strategy? Are you a push environment or a pull? Do you make to stock or make to order? Are you fixed? Do you operate on a fixed order point, or is it on a reorder level? Within the context of pharmaceutical services, we continuously having to look at that trade-off balance. It's the scale that we have to say, do you have enough stock to treat the patient and make sure that the patient's service level and the benefit is high? But what is the cost trade-off, on the other hand, that needs to be considered? So the approach for this project around optimizing our replenishment planning was kind of several steps that we looked at. If you listen to John Katana this morning, he said, if you're not digitizing your supply chain, then you're dead in the water. And really, that's what we've been trying to do. We've been trying to optimize and automate our replenishment planning at facility level, at those clinics that's so dearly needed, and really learned many things. One of them is, or kind of found that we had to do many things. One of them was master data. Master data had to be in place, and we'll speak a bit more about that, but critical for our project. We also had to make sure that we knew what are the items that we are keeping at at the facilities. We did the baseline assessments at the sites with as is to make sure that we understand the context of where we're coming from, and we designed a future state with all the approaches that we wanted to have, all the technologies and solutions that were appropriate for this environment. And then kind of almost key across all of these is how did we involve the stakeholders? How did we make sure that the stakeholders were part of the journey, that we involved them from the outset, got buy-in and approval? That's very important in this environment, working with people across the public sector, and really how do we take them through a period of change? We looked at change management and how do we help people change throughout the process. Finally, we said, how do we learn, review, and adjust, and then repeat? And it was a period of ongoing review that we looked at across the project. And really, this is the basic approach that we took. So to start us off, it was identifying the medicines required. And one of the things in this environment is what we have had actually in South Africa for quite a long time is what we call an essential medicines list. It's a list that gets compiled and updated on a fairly regular basis of all the essential medicines that are required in South Africa to treat the South African population. And then defining how that medicine will be used, which is then a standard treatment guideline to say, this is what you need for the treatment of this specific ailment, and this is the specific medicine that you would apply. What has been great for my project is that these standard treatment guidelines have been put in place, and we could leverage off this work that was done previously. We needed to know what medicines should be kept at each facility, and the standard treatment guidelines could help us do that. Master data, need I say more? It's been the bane of many of our lives, and I'm sadly to report that it's no different in the Department of Health. Master data, in essence, is really just a way of referring to things. Now, if you think of my medicine, it seems quite simple, but actually it comprises of one or many different ingredients, and these ingredients have to be called out. Each of these ingredients would have a specific strength, and all of those together would have a single dosage form when it's combined. That could be either a tablet, a liquid, a powder, and there's many other, an injection, there's many other different types of medicines. A medicine pack is then taking a medicine and saying, well, is it in a pack of 30s, like this one here? Comes in 30s. Often we talk about 28s or 56s or 84s. So those are typical pack sizes, or volumetric if it was a liquid. Then when the department procures these items, it goes onto a contract, and then we are able to establish what we affectionately refer to as the MHPL, or the Master Health Product List. This is a list of all the products that we keep within the Department of Health, and we get specific codes and specific descriptions that we have. These products, of course, are found at different facilities. These facilities need a master, location master, and at the end, we can then draft a facility formulary. So we know at a specific facility what product do they need to keep. And this has been a journey over a period of time to come up with this, to align then to the essential medicine list and the agreed formulary for a specific province. As we spoke about master data, it really can become the core of any environment, and is required to. And we've, through this project work that I've been doing and some of my colleagues working on the project, have been able to put this master data in place. It really allows us to align the different elements. If you think about national contracting, the warehouse replenishment and stock management, it allows us alignment in the prescribing environment and the dispensing. And of course, for my project, the facility replenishment and facility stock management. Automating, as I will tell you now in terms of our story, automating this journey without master data in place would seem an almost impossible task. And so it was a key building block that we had to lean on. So what was the new approach that we took in this environment? And to understand what we had to design as a new approach, we had to look at what was the legacy before. The legacy process was, as you can see, Vaneshri there, manually counting the different items. A planning process at the clinics around the country, which is really a very stressful, time-consuming process to make sure that the medicine room always has enough medicines and are stocked to the right level. The other colleague that I worked closely with, professional nurse Masemola, was a nurse, and that was part of his job. And he also had to maintain the medicine room in his specific clinic. And so there was this complexity about having to balance another job with keeping the medicine room going. And in this environment, the medicine was managed very much on a paper-based process. You can see a bin card there that they have to complete and keep up to date. They would then transfer the bin card stock on hand onto an order sheet, into a manual file. That manual file would be completed for the full order. And my experience, what I saw is that often they wouldn't have time to do this properly, so they'd kind of scan the shelf and say, I need some of this, I need some of that. That file would then be shipped off to a sending site that would then receive the file, and they would then capture the items after having reviewed them. They would capture them onto the system. They would then go through a review and an approval, and only then would they be able to start processing the order. As you can imagine, this process is cumbersome, really prone to errors. There was a lot of duplication of effort. That's a very manual process, and there's manual recapture that had to happen. It takes a very long time from the time an order gets initiated till it gets delivered. It took a very long time, and the process is not standard across the different provinces across the countries, and sometimes not even within a province within the province it wasn't standard process. So we realized we needed to move to a new approach, and we designed this new methodology. Really, it was with the aim of taking some of that supply chain tasks away from the healthcare practitioners, take that burden away and standardize the approach and automate it as far as we can. We came up with standard approaches in terms of the process, the inventory management methodology, and we made sure that we enabled it with technology. And I'll talk a bit more about the technology solutions in a minute around what we used, but it was a computer-based and handheld technology that we looked at. And really the main concept was, how do we move away from manual tasks, free up the staff to do the work that they need to do, and focus on a properly thought out replenishment process that is enabled with technology. So part of the as-is analysis, we did a proof of concept actually in several provinces. We first did it in Northwest at 4 sites in the Northwest, and then 5 additional sites in the Free State where we looked at doing this proof of concept. And part of that, we did an as-is analysis to better understand. And this is just an example of an as-is analysis. We would look at their current formulary of the items that they keep at the facility. And in this case, we saw 411 items that they keep, of which 270 odd were pharmaceutical products, which was the main focus for this piece of work. We also looked at how they're keeping in terms of how they're doing in terms of inventory management. And in this case, significant amount of items were overstocked, but there was also a considerable amount that actually were below safety stock and putting the facility at risk of stocking out. We then finally did some segmentation analysis, and we would look at, well, what is the number of items that make up the 80% of your volume? And you can see about 40 items would do that. And even more so on the value side, only 6 items make up 80% of the total value. And we would then say, how do we focus on those high volume, high value items? And you can see in the 4x4 matrix that we wanted to focus on those white items that are listed there in the top left quadrant, to really try and see how do we hold less inventory of those but replenish more often. We also looked at the VEN status, which is really a classification from the department looking at what is vital, what is essential, and really what is necessary to be keeping. And the vital items are the items that we wanted to make sure have potentially a differentiated supply chain. Again, if you heard from John Katana, that you actually need to differentiate your supply chain. And we try to see how do we do that and potentially have different strategies for different items at a facility level. We also looked at the process in terms of the replenishment cycle, and you can see that depicted here. We wanted to automate that requisition coming from a health facility and make sure that it's a sound order that gets placed based on analytically sound min-max levels and parameters. We also wanted to make sure that there was a central support team that could support the facilities and kind of support the province as a whole in overseeing and managing the inventory for the province. The central team would look at the order, make sure that the facility is actually holding the right level of stock, pick up if there's some items where maybe they've kind of over-egged it, that they've ordered 1,000 items, but they should actually only be keeping 100 in stock. They also have the ability to kind of balance the province in terms of stock holding if there's too much stock in the one site, to potentially move it to a site where there's not enough stock. And in a low stock environment, do things like fair sharing the stock across the province. We also looked at the replenishment methodology. Ideally, and this is something that Colin would be very familiar with, is that we ideally wanted to operate within that cycle stock environment. We wanted to be in the green, and we know that we also needed that kind of yellow, which is the lead time buffer in our environment. So we said we wanted to play in that environment and make sure that we don't dip into the safety stock too often, and that we don't hold excess stock. And so that's how we came up with how we're going to be operating. We set up some guiding principles in this journey. Some of them was to really leverage the technology that's available. So we weren't introducing new technology. To automate the process as far as we can, which we've spoken about. To come up with a standard approach that's repeatable, and to make sure that that repeatable rhythm gets going. To make sure that everyone understands the requirement for data and accurate stock. You know, we needed to have accurate stock levels to drive the system, and to ensure that there were focused teams to help monitor and support the process. So what was the solution that we came up with in terms of the technology? The automation was based on two solutions. The one was called Oryx Solution. This is a desktop-based inventory management system, really a nice system, a little bit dated by now, but working fine. And it's a transaction-based system. So every item that you capture, every item that you receive, you capture onto the system. Every item that you dispense, you capture onto the system. You make sure that if you're writing off stock, it gets captured. And in that way, Oryx Solution almost gives you a snapshot at any point in time of the inventory situation that you have in your facility. And that then enables you to place these, what we call automatic recommended orders, or automate the ordering process. The orders would then be based on the current stock on hand that the system would have, and the analytically sound min-max levels that were set as part of the journey. So that Oryx solution would then also be integrated into another WMS system as far as possible, and that then also further eliminates the requirement to recapture the order onto another system and another platform, and that way reduce the workload and increase the accuracy of our orders. The second approach was to use what we call a stock visibility system. It really used a handheld device to capture the stock, and we've recently added a ordering module to that. The stock visibility system was in the past really just being used to try and get a snapshot in time, sort of like a picture of how much stock we have, and are there any facilities around the country where we're in trouble in terms of stock. So it's something that was deployed across the country, across the 4,000 odd facilities, where we're getting regular weekly reads of the stock on hand. But that's where the functionality ended. The functionality was then transitioned, and we then introduced recently this what we call then enabling it with ordering functionality. You'll see three components in this diagram. There's the top part where you set up on the device, you set up the order schedule, how frequently you're going to be ordering, you set up your parameters for your ordering, and you set up the full items that you're going to be keeping your facility formary. Then the beauty of it is that as the user uses the handheld, they would be capturing their stock on hand for the items that they keep. Every time they capture an item, it will automatically tell the user if they need to place an order for that item, and it generates the quantity that they meant to order based on the parameters that we've set. The user can then decide to change the order, to potentially amend it to something different if they believe that they need more or less, but they need to give, of course, a reason for why they're ordering differently to what the system recommended. And as we go, we wanted to learn from that and change our parameter settings. It's not AI yet, but we're getting there. And then once they've placed the order and confirmed it, that order moves to an approver. The approver would actually get that order on a web-based platform. So they would review the order. So the order gets automatically sent from the handheld. No more needing a card to take that paper-based file across to the other site. It's available. They get an alert that they've received an order. They open it up, review it, agree to the order. They can also change it if required, agree to the order, and then process the order. That order will then get uploaded onto the WMS system at the facility, the warehouse management system, where they can then process the order and actually ship the stock to the facility. It's a far cry from the paper-based system that we had before, and really exciting to see us being able to move sort of steps closer in terms of automating this very manual process in the past. You'll see the last part there was the e-receiving, something that we still actually are in testing phase on, but it's also to allow us the capability to know when the stock was received and how much stock was received at that point in time. So in terms of selecting the systems, looking at RX Solution and SVS, we realized that actually RX Solution is the choice tool to use because it really is an inventory management system, but it requires some preset conditions. It needs us to have good connectivity. You need to be able to be in an environment where connectivity is set up and it's good connectivity. You need to have a computer and a printer in place, and you need to have a full-time pharmacy assistant that actually will manage that stock room and that medicine room and keep the system updated and manage the stock on the system. The alternative for us is the stock visibility system, which is SVS. And typically we'd look at SVS in smaller nurse-driven clinics where RX Solution is not a feasible solution. And really what we see with SVS is that it provides us a great platform to be able to scale the solution. These handhelds are already in all the facilities. They're already capturing their stock. And now we need to enable that by doing a proper setup for the replenishment planning parameters, set up their full formulary, their full item list that they keep, and then train them in how to use the system. And so we are able to hopefully scale the solution very quickly. So what were the results that we saw from the work that we did? Really, for both RX Solution and for SVS, we saw a significant improvement in terms of our stock holding. We saw a lot more of our stock sitting in the green, and the items that are still sitting in the red, we saw a dramatic reduction in those. Of course, there's always opportunities for further improvement, and we continuously will work towards that. We also saw, as a result of this, a decline in out of stocks at these facilities. And that was really very pleasing for us to see the out of stocks come down, your stock level come into an ideal stock holding range, remove some of the declutter, remove some of the write-offs that we had previously seen. We also heard from the users, Vaneshri, who was one of the users that we went live on for the RX Solution. She said that, hey, automation has really saved a lot of time, and she's seen the accuracy of her orders improve and her availability improve. Sometimes some products aren't available, but that is actually from a greater upstream supply point of view. But for her facility, really very happy to manage in that way using the technology available. Professional nurse Masemola also said he really knows that his order is going to be accurate. And that was a key thing for us to say, how do we make sure that the user can trust the system, that they can actually make sure that when they are capturing their stock on hand and the system recommends an order, that they know that this order is the correct order. And that's why we also had to continuously evolve the process and continuously update the parameter settings. He also said that his out of stocks have reduced a lot, which was pleasing to see. Finally, we also said we needed to have regular reviews. Now, one of the things that the Department of Health has done over a period of time is to put a national surveillance center in place. This national surveillance center, as you can see from the graphics, is a very visual way of showing the data, allowing managers very quick response time to pick up if there are any issues or any concerns, to pick up where the areas are, and then to make plans to actually drive the change that's required. The stock on hand dashboard is something that's been established over time, and you can see there it's something that's matured, and we can try and see, we've got up to 88% availability at clinics. We still know that we can continue to drive and have targets of the mid-90s, 95%, where we'd like to be. Measuring the out of stock, or measuring our stock on hand, is something that we are working on at the moment, and really would like to see on this surveillance center how that stock trends over time, and are we on a regular basis within the band that we want to operate, or are we dipping into safety stock too often? And if we are, then for that item, do we go and change those input parameters? And so how do we make sure the surveillance center can help the managers and the pharmacists that are looking at this medicine on a regular basis continuously improve the availability they have? So as I wrap up, we all have a chance to be a hero every day, I think. Each of you impact the lives of many of you around us. And you heard from one of the speakers earlier this morning that, that work-life balance. How do you impact the lives of your family, the people around you? Through the involvement in the Global Health Supply Chain Technical Assistance Program, I've been able to improve the replenishment planning systems and hopefully help save some lives. There are many lessons that we've learned from this journey that really form a foundation for our further improvements. And I'm just going to share a few with you as I close today. First one is how do you leverage what you have and continue building on it? Continue building on those platforms that are already in place. How do you make sure that people know the importance of data, garbage in, garbage out? If we don't have good data, then no matter what process we put in place, what system we automate with, you won't get a good outcome. And so paramount to have the right data available. We need to be able to share where you're at, engage with stakeholders, take them along on the journey, and really communicate as often as you can. Drive the change management that you need. Make sure that you invest in getting things set up properly. You need to have a sustainable solution. When I leave this environment, we don't want the solution to fall apart. And really, it's how do we make sure that there's preparation, proper foundations in place, and that we then actually get things set up properly. We've also realized that automating is not the silver bullet. We'd love to see AI and other technologies work in our environment, but if your process isn't fixed and you apply technology, then you're just exacerbating the problem. Fix the process first, and then you add technology to help you to improve that and make it a better process. Maybe that leads into the next point, standardization. Make the process standard and as repeatable as often, especially if you're going to be going to 4,000 facilities around the country. We needed something that is going to work, it's easy to implement, and it's sustainable. And then advocate for people to review things on a regular basis. As you saw in the National Surveillance Center, we want to make sure that people are going to start using that platform on a more regular basis and make sure that they can actually find where the problems are early, use it as an early warning system rather than responding to failures, and then pick up on how they can drive improvement. So in closing, I want to agree with J.K. Rowling, who said, every human life is worth the same. and it's worth saving. And we hope that what we've done is contributing to that in a small way. I thank you. And I think I'll hand back over to Colin.
Yeah, thanks very much, David, for an inspiring presentation. It's wonderful to hear good news from the public sector for a change. There are quite a few questions. If you'll just click on the discuss button, you'll see there's there's comments and questions, and I wondered if you could take a few of those questions. We've got about 10 minutes to spare.
Okay, I'm just quickly going through them.
And while we're waiting, let's remind the audience, please would you click on the poll button and give us your opinion about this presentation.
Yeah, so I think, Colin, as I look through the first two, those are really supporting. So I think that's great, and definitely agree in terms of the standard treatment guideline and the essential medicine list. I think it's really how do we implement them. Maybe using supply chain terms that's familiar to me. There was a question about as is. It really is the as things stand at the moment. As is assessment is looking at how things are at the moment, and then there's a 2B, which is the design of the future state. So maybe that was just a very quick answer, and I see somebody contributed to that. There was a question here, stock visibility system, any public health facilities using the system? They are being used across the country. So almost out of the 4,000 facilities, there are a handful that are hospitals and bigger facilities that are using other systems like RX Solution. But we do see most clinics around the country are using SVS. They're using it currently really just as a reporting tool. So it's really just reporting on how many, what your stock on hand is. And then we can very quickly see as a snapshot across the country, are we in trouble? Are there some items that are endemically out of stock across the whole country? Or is it really localized to that specific facility? And how do we respond? And then the new addition to that stock visibility system is really this enhancement with the e-ordering and being able to enable the ordering. Most of the time we hear there's no budget in public health. How does development programs cost management? I think that definitely is a problem. I think a lot of the times when they do have stock shortages, it's because of the budgets. 20 billion rand is being set aside for medicine. And one of the things that we've been doing, which is maybe off topic on this specific presentation, but one of the other pieces of work that I've been helping the department with is around demand planning and setting up demand forecasting for the department. And part of the work in that space is then to set up the budgets and almost zero-based budgeting to say, well, what does the budget for the next financial year look like? Based on a very well thought through or kind of scientific approach to budgeting. And in that way, we can then give them the budget. I think the big challenge to us that we're still seeing is how do we make sure that that budget indeed gets allocated to the pharmaceutical services and gets used for medicine, because they might agree to a budget, but they might not then allocate those funds. And that's where the pharmaceutical services team are really crying out. And there was a presidential health summit in 2018 where they said that these funds need to be ring-fenced. And we're working towards trying to say, how do you ring-fence these budgets around that? And so that's something that we're specifically looking at. Colin, I'm just quickly going through the last few here. As I understand, facilities either choose SVS and RX, but do these both systems integrate into the same master data tool for order management? And that is definitely what we are trying to do. SVS is direct onto master data. RX is a bit more challenging because RX is a standalone implementation at a facility. And so there's a lot of work in trying to upgrade these RX to make sure that the master data is correct. As the master data changes, of course, those changes have to be made. And so I think as they're looking at RX over time, they're saying, well, how does that become a cloud-based solution that you can actually do that integration. There's another question here around, is there an intent to expand this process to the procurement of surgical items? Surgicals is a minefield. I think, Jason, thank you for the question. And I think long-term for sure. But on the short term, we've really focused on medicines because medicine has those essential medicine lists and standard treatment guidelines. There's nothing like that in the surgical environment at the moment. And surgicals, really, we see it as an opportunity, but not something that is something that we are able to kind of tackle at this point in time. Interesting with COVID, it did provide us a platform where we realized that with the whole PPE, of course, you realize that you actually needed to start solving the supply chain challenge for these, what we call kind of, I suppose, surgical or consumable items. And so that has put a lot of, it's helped us advance very quickly. And I think everyone realizes the need for it. I think we're all a bit scared of it because there's a kind of big nightmare waiting when you delve into that area. But it definitely is something that is on the horizon and something that we need to look at. And really, from my point of view, fortunately for the clinics, it's not something that you're ordering on a regular basis. You order a box of 500 gloves, and then you don't order it again for another 3 months, and then you maybe order again. So at the moment, they still have to order that on a different process, but something that we're looking at. Colin, thanks for your question on the application of DDMRP. We actually had some good discussions with one of your colleagues in the DDMRP space around trying that out. I think what we are saying is that we're biting off one, or we're taking one bite at a time. And so the first part was to try and get this alignment, get these two standard processes working. We are keen to try something like DDMRP in maybe a localized set of clinics in Gauteng. And that's something that was on the cards, but we're not there yet. There's a last question I see here. Are the users adhering to the new process? Do they revert back to the manual process? So we do keep the manual process in case of technology failure. So if the system is down or if there's a concern for some reason that we can then go back to that manual process. But largely, once you've made the transition, the guys don't want to move. And in the Free State, at the 5 facilities that we saw, the person who was leading that work was a district pharmacist, Jana. And she actually, after we did the SVS go live, which was the first part, and then we followed with Oryx a bit later, and that was all trying to do that remotely this year with kind of all online platforms, trying to train online, which was very different to the way we'd done it before. And Jana came back to us and said, hey, when do we roll this out to the rest of my facilities? Because I'm very keen to use this. And so I think there's a very good adoption rate. But we also realize that you must first walk before you run and get the process sorted out. Make sure that the supply chain processes are well established, that we set those min-max levels, that we actually have a good methodology in how to replenish. And then we make sure that we then enable that with the technology solution. So, Colin, I think I've run through. I see one last one kind of popping up saying, is it user-friendly? Maybe one comment on that. Oryx is a bit more challenging. We kind of train people over a period of a week and then have to come back in about a month's time and kind of see where they've reverted into bad habits and try and teach them some new parts to it. But it's like any system, as soon as you use it on a regular basis, you master it. SVS, interestingly enough, we had a failure where it went live at a few facilities before we actually were intending it to go live. And we had 1 or 2 people coming back to us to say, well, they've now placed their order using the handheld, and where do they go to see this order? And that really was for us a very positive in a way, because we realized that, hey, people were intuitively figuring this out without us having to train them. So we believe it's user-friendly, but I think time will tell as we go. And we've now got the first 9 facilities live using this, and we'll continue adding to that as we go.
Right, David.
I think we're out of time.
We're on time, so I'd like to wrap up. Thank you very much for offering this presentation to SAPEX this year, and I'm sure the audience enjoyed it. A great response from the audience. I got a lot out of it. It's a real good news story, and please do keep up the good work. Thank you very much.
Thank you, Colin. Great to be with you all.